Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I'm glad to have Drew and Mark on again. And today we're going to be talking about evidence versus experience and breaking down all things in between, especially in regards to the outpatient realm. But first is Thanksgiving week. So our icebreaker is going to be for both you guys. What item has got to be on the Thanksgiving Day table, or else there will be a rebellion? So Drew, let's start with you.
For me, personally, growing up in Amish country, pies are it. The specific kind of pumpkin pie that my mom makes, and then also peanut butter cream pie. Those have to be on the table, and that's my favorite part of the meal, the dessert.
Yeah, I feel like with Thanksgiving, dessert, main entrees, they all kind of blend. It's just a mix, and it's absolutely acceptable.
Yeah, the sweet potato casserole is basically a dessert disguised as a side dish, and so it's definitely got to be part of it.
Yeah, I like that. My
I don't like imposters, so I could do without it.
I'm gonna go a little less conventional. My wife makes some incredible collards, and that's always been a mainstay for me since I was younger. They're Midwest, and so it's a little strange to all her family with that we're with at Thanksgiving, but that's okay. It's still good. My brother-in-law, I think, has perfected the turkey on the green egg, so that's actually a good stay. So jumping right in here, evidence versus experience, really trying to break down. We know that we have clinical practice guidelines. We know we have meta-analysis. We know we have a lot of research over the years in terms of what we see positive effects with in terms of treatment and non-positive effects. We know those CPGs can change periodically as well too. Likewise, we know that as we work in a clinic, as we work in an outpatient clinical setting, your experience is going to see some things that you feel like allow you to get people better. And sometimes it does or does not agree with evidence on some level. So, kind of big picture, backing out here just to touch. Can you think of a time when evidence changed your clinical behavior? Start us off here, Mark.
So the best example for me is in PT school. Oftentimes they do teach for tendinopathies to stretch, and some of the research that has come out, especially from Australia, particularly in the 2010s, has supported actually not stretching for blood flow reasons and tensile forces and all the other very physiological things. When I found that out, I haven't totally excluded them from my practice with tendinopathies, but like especially early on, I have taken them out, and it actually has made a significant difference in my outcomes. So that's the best example I can think of.
Yeah, I was thinking a little the same thing, especially for me. The differentiating between the proximal and the distal tendinopathies on the Achilles. That's a good example there. Kind of on a different side of things, Drew, what do you think? Tell me about a time that you have followed the evidence to a T perfectly. This patient should get better, and they didn't.
Yeah, and I don't know if I've mentioned this one on here before, but it was a patient with low back pain, a mechanical low back pain, non-radiating, fit the manipulation, mobilization bucket to a T. It was fairly recent, nothing radiating. And so we did that and like no change. I was like, all right, well, what else? What else is there? Is there directional preference? And it didn't really seem to be one. There wasn't a shift or anything like that. But we're like, well, let's see if we get like a little bit of help, and like see if it changes slightly. Like maybe there was a slight change. Tried that. No. And then I started going to, all right, well, what about some other things like dry needling? Still no change. I think I probably even tried some like stabilization stuff and like just not getting anywhere. And eventually, as you can expect, she was like, well, it's not getting better. And she did go elsewhere. And I ended up seeing her several months afterwards. And so I was like, oh, how's it going? How are things? And she's like, I'm so much better. Like you wouldn't believe. It only took like one or two visits. I went to see this person, and I had just had a lot of inflammation, and they did ultrasound, and that just like almost immediately just took it away. And I'm like, I'm like raging inside, but then have to be like happy for her, but also just kind of like that's so against everything that we supposedly know about low back pain and what's supposed to help. So yeah, that one was a frustrating one because tried to follow everything that we know and
So
just didn't work.
you now have changed up your practice pattern, and everybody gets ultrasound on the first
Everybody
visit
gets
for low back pain.
right.
No, just kidding. I mean, so
Still
kind
not.
of veering into that. So how how would you guys, from a big picture view, like how do you determine when to follow guidelines versus the patient in front of you? And by that, obviously using your clinical experience and tailoring it to the patient standing there. Mark, you got any thoughts on that?
Well, I think that's where the evidence is going in this next decade, really is yes, we have like your nociceptive drivers for pain, and we have a pretty good idea of the things that should be effective for treating those very nociceptive conditions. But the problem is that that doesn't account for all of the other things that influence pain, and that's the kind of the human experience. And so when you look at the three pillars of evidence-based practice, you know, you've got patient values, you've got current best evidence, and you've got clinician experience, right? And Drew clearly missed the patient value side of thing in the case that he was talking about. Should have broken out the ultrasound from day one. But no, in all seriousness, like we have to remember that clinical practice guidelines are like the current best available evidence for us, but that not every patient is going to fit into those categories. We have humans that have all kinds of beliefs, backgrounds, stressors, sleep patterns, all kinds of things that can influence their experience. And if we're not taking into consideration those things, then the evidence, and that's, like I said, that's where the evidence is going, is taking into consideration of those things in the future. So if we neglect that, it's going to affect our outcomes.
Yeah, I think that's great. I remember a mentor giving the phrase "patients don't read textbooks," and that kind of stuck with me a little bit. And it does. You see that fit very often. Like, oh man, I got this pattern, and it just ends up being a little bit different sometimes. So, absolutely, Drew. Any thoughts on that?
I think Mark summed it up pretty darn well. What was the actual? I love what he said. What was the specific question you asked?
Yeah, so I was kind of going to when do you determine to follow guidelines versus
Yeah,
what
yeah,
the patient in front of you is displaying.
yeah. Well, like you said, one patient values. That's a key one. That's one of the key legs of the stool of evidence based practice. And then I think it was definitely helpful early in my career when I had little to no, clinical experience. It's a great place to start, and it should be where we start. Like it's the thing that has been proven the most, but even the most home run studies, like you don't have 100% success rate. And like Mark said, there's so many contextual factors with so many patients that you have to take into consideration those. And that's probably where I have missed the boat a lot, especially early on, because we learn the nociceptive driven thing, and that's what we go with. And when that doesn't work, we're like, oh, now what?
Yeah, I think some good points there. As you guys were talking through this, what came to my mind is dry needling for me. And I know it may look different for everybody how you're trained, but I feel like over the years, I mean, I've been doing it for 11 years now within practice, and it's not a mainstay for me. It's kind of moved more to being a means to an end. But if a patient comes in thinking they need dry needling, more than likely I am going to dry needle them and hopefully also do what I think is best. If a patient does not want to get dry needled and I think it's a really useful technique for them, I can suggest it, but 9 times out of 10, if I have to convince somebody to get dry needled, it doesn't go well, no matter how much I think it's the right clinical decision making. So I think, to your point, there's a ton of value to blending those things together and making sure that the beliefs exist there, and still following your gut on what you think is going to be the best treatment. It's practicing medicine, and that's what we're here to do. And so I think that has a lot of bearing on it. So that was kind of what came to mind for me. One last thought before we finish up here. What is the danger to over intellectualizing a patient encounter? And just kind of what I mean by that is over explaining, maybe digging beyond in the evidence what the patient may need to hear as you're speaking with them. So you guys, for either of you that wants to address.
As far as presenting a lot of the evidence and things to the patient, I think it's going to depend on the patient itself. But I do like to use, when there's studies that show, hey, this patient is going to get better, the non-specific treatment effects, I'm going to use those to my and the patient's advantage. When you talk about manual therapy, manipulations, things like that, when you're introducing it and say, hey, here's what I think is going to be helpful, patients who are similar to you, like if we can do this treatment, do X, Y, and Z, patients tend to do really well with that. And I think it's going to help decrease pain and help you move better. Right. And then we go on and say, and then when you're feeling better, I want to do X, Y, and Z as well. And this is how you're going to maintain that. But setting the expectation for them to recognize, hey, there's value in this is key, because if they don't see value in it and you're like, well, let's just try this thing, and they have no context, in my mind, I think you're probably going to be less likely to be successful, because expectations drive outcomes. And if they expect to feel better because of this, then I think the chances of them actually feeling better are much higher.
To go on to that, I think I agree with everything that Drew was just saying. There is a risk of overdoing it, and so it's kind of meeting the patient where they're at, especially early on. As a new grad, like, I knew all of these things and wanted to tell my patient all of these things, but truthfully, most patients don't actually care about all of that, right? They want to know a few things, right? The Louis Gifford's 4 questions, that's really what they kind of want to know. And as long as you hit those 4 things and you back it with a little bit of evidence, like Drew was saying, like, hey, this should be helpful for you. This is, you fit this presentation that has been researched, and so, whatever. If you go too far beyond that, you run the risk of essentially overdosing your education, which can also backfire in negative ways.
Yeah, I think that's well said. And that's one of the reasons why I really enjoy having students and even shadows potentially, because you get to communicate a lot of things that you do know, and patients get to see that you know a lot more than they actually were thinking initially, but at the same time not kind of talking over their heads. So I think there's a ton of value in mixing those things together. So good thoughts. I appreciate it, guys. Good information on kind of working these things together. Until next time, you guys have a happy Thanksgiving.
Thanks.